Good morning, everyone, or good afternoon, depending on where you're joining us from. I'm going to give people another minute to join and trickle in, but a quick introduction. My name is Stephanie. I'm with the Patient Story, and I am so excited to have everyone here today joining us for this very important conversation titled How to Empower Yourself After Diagnosis. Something that's very personal to me and to everyone on our panel in so many different respects. So I'm so glad that everyone who's here could join us, and I want to be able to cover as much ground as possible. Today, we're going to really have three major sections, if you will, in this conversation. The first part will be about getting diagnosed. The second part will be about treatment and side effects. And the third one will be about navigating life with cancer, which, as we all know, is it's a big topic. It's a lot of ground to cover. So again, hello to everyone who's here. And I want to take this first time to introduce our incredible panel of voices. And I will let each of our panelists introduce themselves in a little more detail. And I want to start with Karen DeMairo, who is the Vice President of Education, Support, and Integration at the Leukemia and Lymphoma Society. So Karen, I'm going to spotlight you now, and please introduce yourself.
Thank you, Stephanie. Thank you for having me today. As Stephanie said, I'm the Vice President of Education, Support, and Integration for the Leukemia and Lymphoma Society. And what that means is I oversee all of our education and a number of our support programs, including everything that's on the website, all of our educational materials, our videos, our webinars, our podcasts, things like that, as well as a number of the support programs that we have, including our LLS community, some of our other things such as the chats, our nutrition services, and then some special projects that come up along the way, including our outreach to underserved communities.
Thank you so much, Karen. I appreciate that. Dr. Miklos, I was able to, hear your name first when I interviewed one of your former patients, and they were raving about you. So I'm really, thrilled that I was able to talk to you for the Patient Story. Can you talk a little bit more about what you do there at Stanford and what drives you to do the work?
Thanks, Stephanie. Thanks for inviting me to participate today. Patient outreach is definitely one of our priorities. So I'm the chief of the blood, marrow, and cell therapy program here at Stanford. That includes the allogeneic transplants, the autologous, and then the CAR T. I have a career of working on correlative translational research going back 20-some years to my training at the Dana-Farber, and now here at Stanford, trying to carry this forward. Have been involved in CAR T since the Zuma-1 studies of 2015. Again, you said it, patient outreach, educational materials, helping empower the patients is critical. There are many technological obstructions and some, let's say, litigious problems out there, but these outreach webinars are a great way to start. So thank you for having me here today. And I just can't say enough of my colleagues at Stanford. If you have those kind of problems, we can help you.
Thank you so much for that. Really appreciate that introduction. And last but not least, of course, Mags Bujalski, who's a fellow non-Hodgkin lymphoma thriver. Mags, I was able to, talk to you for your story about a year or a little over a year ago. And I would love for you to introduce yourself outside of the cancer context, because of course we're so much more than that. And then after that, if you could just go ahead and dive right into what it was like getting diagnosed, that will segue into our first part of the conversation.
Yeah, absolutely. Thank you for having me, Stephanie, and hello to everyone. Thanks for joining us. My name is Megs. I'm currently 24 years old. I live in Canada. I work as a translator from French into English. I'm a dog mom. I love to be on social media, run my YouTube channel. I recently started a blog. So that's basically like me in a nutshell outside of my cancer diagnosis. I was diagnosed when I was 22 years old. To make a long story short, I basically had a really weird swelling in my arm and a really bad cough. Didn't think those two were related at all. And I ended up going to a walk-in clinic. The doctor was amazing, sent me for testing. And when it came back looking funky, she sent me for further testing. After a few weeks, I found out that I had stage 4 primary mediastinal large B-cell lymphoma. And my world was kind of shaken upside down. It was definitely a weird period in my life. I had just moved out with my boyfriend. I was really close to finishing university. I had just agreed to work at like my dream company. And then I had this crazy diagnosis and I didn't even know a thing about cancer at the time. And so for me, it changed my life in like a completely different way. It was really hard, but it also taught me a lot. And so I'm sure Stephanie will agree. It's a very life-changing experience at any point in your life. But when you're younger and it's kind of like this weird point of you're trying to grow up and figure out who you are, but you're facing all these crazy challenges that you never even imagined you'd have to face. It's definitely something that changes you a lot. But I mean, coming out of the other end of it, I definitely have a whole new respect for this whole world of cancer research, cancer treatment. So it's definitely amazing. And I've learned a lot.
Thank you so much for that, Mags. I know it feels like not that long ago, even though it was 4 years ago I was diagnosed, but sometimes I just kind of feel like it was the other day, right? Like there are these vivid sort of parts of the memory and it stays with us. And we'll talk about that a little bit later too, in terms of the survivorship. It's a big topic. So thank you, Mags, for introducing your story. Dr. Miklos, I know that when you say non-Hodgkin lymphoma, it actually means a lot of different things. There's dozens of subtypes. But if we were, we have a short time, but if you were to cover sort of in general, what does it mean when you get diagnosed with the B-cell lymphoma?
Sure, Stephanie. Great point. When we consider blood B lymphocyte cancer, it's a little different than what we hear when people say lung cancer or breast cancer. Lung cancer, 180,000 patients are diagnosed with this, and we call it small cell or non-small cell. We're not very reductionistic about that. And I'm sure there's much more biology to lung cancer that we're all anxiously waiting to learn more about. But in again, lymphoma or non-Hodgkin's lymphoma. And I'm going to put Hodgkin's disease in here for a second, because what we're really talking about are the B lymphocytes that are integral to our adaptive immune responses. We're all students of immunology now that we've discussed our COVID vaccines and which one's the best. And, oh, I had that immune response with fevers and achiness and maybe some lymphadenopathy. So we understand immunity, which has evolved over 10,000 generations to become the most powerful way to eliminate those foreign proteins, microbes, viruses in our body. So here's the untoward bad outcomes of having an adaptive immune system. What you need to know about the B and T lymphocytes are that, unlike every cell in the body, these cells are allowed to genetically change, mutate, intrachromosomally recombine the DNA of the adaptive immune receptors. And so the lymphocytes are a bit of wild cards in your body. They provide the immunity so that you can recognize 10 to the 12th different antigens in the world. That's the Cosmos moment, right? Carl Sagan, billions and billions of antigens. But they are doing this by taking a risk, by the rearrangement, the mutagenesis of the receptors that are only expressed in the T and B lymphocytes. So this is what really makes these molecules unique. And they go through a maturation from a undifferentiated lymphocyte progenitor or a stem cell to the final B cell that's making antibodies called a plasma cell. And they have correlates that are cancers that correspond to failure to proceed through the natural development of the B immunity. And each one of these has a different name. So an early stage would give you acute lymphoblastic leukemia. A late stage in the plasma cells would give you multiple myeloma. The problems that we're talking about today of non-Hodgkin's lymphoma are frequently starting with with chronic lymphocyte leukemia, going through, as listed here, follicular lymphomas, Burkitt lymphoma, mantle cell lymphoma, marginal zone lymphoma. We got 25 names, and they really represent the individual breakages as normal maturation in the immune system blocks. And the normal progression breaks down due to mutations. And these mutations are occurring because essentially these cells are allowed to mutate. Now, here's the sobering thought. If we had put all those malignancies that have the B lymphocyte together, we would have about 150,000 newly diagnosed patients every year with a B lymphocyte cancer. So it's right up there with lung cancer, breast cancer, and prostate cancer. We just give them different names. And so, Stephanie, I think that's really important. And it's probably not going to surprise you that the most important thing that the patient needs to focus on at the beginning is making sure of the diagnosis, because these names are tricky. And what I tell all of my family and friends when they say, could you refer me to a doctor, or how do I help my friend Charlie? Go to a large referral center, make sure your pathology is reviewed, and make sure you're part of a multimodality review at that center.
Perfect. Thank you. So I know that was a lot to cover, so I appreciate you summing that up. And we're going to go into questions to ask too, because that was a popular topic, for people. I do want to ask Karen, again, from the LLS, about some of the resources, for patients and caregivers to better understand what a diagnosis is and what it brings. So Karen?
Sure. I think first and foremost, we always encourage everyone to call our Information Resource Center. That's our call center, as people will often refer to it. It is staffed with social workers, nurses, health educators that are highly trained oncology specialists, and they are there to answer questions about the disease, about treatments, anything that relates to now being diagnosed with a blood cancer, and specifically here with a lymphoma. I think it's very important to be able to talk to someone who can give them all of that information. And as you can see here, there's a list of resources that we have available. And, they can direct the patient or the caregiver in the right direction to get whatever they need. Some people learn better by speaking to someone, but then if they would like a booklet on lymphoma, or if they want to watch a webinar, or listen to a podcast, or attend an actual program, I think that they should take advantage of whatever information is out there. Here you can see just a graphic of some of the things that we provide. But it's always best to start with one of our specialists, because then they can make sure you're getting the right information for the questions that you have at that time.
Thank you for sharing that. And Karen, I know you've been doing this for almost 25 years at the LLS. What have you found patients and caregivers really, seek information about at that stage?
So with lymphoma, it usually starts with what kind of lymphoma they have. They're not always sure. They kind of think it all gets lumped together, right? So it's having that conversation to say, okay, well, exactly what lymphoma it is, and then to talk about the types of treatment, right? And make sure that they're asking their physician the right questions, getting the information that they need. And then from there, to be honest with you, a lot of times it goes in the direction of financial resources or what other supports there are out there. And I know we're going to talk about some of that later, but that's really the direction it will normally take.
Thanks for sharing that perspective. I thought it was, it's great to talk to someone who, again, has so much experience with patients and caregivers. Mags, we're going to go now into questions to ask, or things that you can do as a patient and as a caregiver to make it easier, right? Like, we've learned through the process some things. So one thing I learned was, when I'm in the appointment with the doctor, a lot of times, especially the first time around, and especially in the beginning when it's super overwhelming, I'm like, I don't remember anything you just said, right? Maybe they covered a lot, but I just don't remember. So someone else told me, hey, I bring in my phone and I ask the doctor, can I record you, just so that I can replay it later. And that way you can share with other people. But I'm going to pull up one of your quotes from a story where you talked about having another set of eyes and ears in the room. So what can you tell people in terms of what helped you?
Absolutely. So I, at the beginning, especially brought my boyfriend with me. He's just like, he knows me better than anyone else. And he was just another set of ears. He would catch the things that I wouldn't catch because I just felt overwhelmed, because when it's talking about you and your problems, you feel overwhelmed. There's lots going on inside your head. So you're not exactly absorbing everything the doctor's telling you. So I bring him. He would also ask questions that I probably didn't think of. And so I think it's important, if you do want to bring someone, that it's someone that you trust, someone that has your best interest at heart, someone who is going to be there to support you and also kind of be there to help you make decisions when you do need to. I would also take notes on my phone. I did record once. So just make sure you always ask your doctor if that's okay. I would take notes on my phone or already come with questions already ready to go to ask. And when it came to like any sort of like papers or scans, I would just always ask for a copy of them so I could take it home and review it later on, kind of when I had already digested and processed everything.
Yeah, I feel like one of the common themes is sort of, again, it's hard to take in all this information, especially when you're in the beginning stages and you're getting the tests done, right? Like the scans, the blood tests, maybe you have a bone marrow biopsy, and everyone's trying to figure out what exactly you're dealing with, as Dr. Miklos was, describing non-Hodgkin lymphoma. I mean, it's dozens of different kinds of things, right? It's dozens of subtypes, B cell, T cell, and everything else. So thanks for that, Mags. I want to ask you, Dr. Miklos, about questions to ask. You're in those conversations. And again, I know it's tough because it depends on what kind of, subtype you've been diagnosed with. But what are some of the considerations, in asking questions, between the patient, caregiver, and doctor? And then we actually also, I noticed we have a question in the Q&A where someone asked, I'm a caretaker. Sometimes it's awkward to engage the oncologist with questions about things I'm reading online, right? The whole Dr. Google thing, stay off Dr. Google. Any tips from you on how to effectively and respectfully do this?
Well, the respectful part is the hardest challenge, right? You want to meet the patient, their care provider, and the team wherever they are. And everybody comes at this from a different angle. Some are professors walking in with a PhD and they want the manuscripts, and others are unaware of what is lymphoma, what is cancer. And so we have to start at the beginning. That's really the job of the physician and his care team. So Stephanie, I think the quick answers are for us is to build materials so that we can spend more time answering the patient's questions and allowing patients to come up to speed with their care providers and their teams before the meeting. And so thank you to the patient story. I find an hour spent with Stephanie turns into about 1,000 hours with my patients, because I frequently, unashamedly just say, go to patientstory.com, go to the LOS website, go to the BMT InfoNet. These are resources that are curated for the patients. And I'd love to have my Stanford information up to date and changing and evolving. But the truth is, I'm either treating patients or working on websites. And so I think that the patient outreach organizations that you're highlighting today are really well positioned, and that the docs in the community should support what works. And so LOS and Patient Story, InfoNet, these are places that we want our patients to go, knowing that they're going to get valid data. Dr. Google, not so sure about. Got to tell you, I spend a lot of time kind of refuting things that patients and families are insistent that they learned on Google. And of course, that does become a little bit distracting at a minimum. So I want to emphasize what Mag says, always come with at least another set of ears. I would definitely not be ashamed to ask me, is it okay if I record you? I do respect when people ask me. Sometimes I don't. That's okay as well. I have a lot of confidence. It comes from years of taking care of patients, and I make mistakes as well. So I often will make some disclosures of what I know and what I don't know. And doctors really feel uncomfortable when they say, I don't know, but I feel very comfortable saying when I don't know the right answer. Those would be my 3 starting points. Again, they're valuing the external information resources, bringing a friend with you, going ahead and asking to record, because it's going to go past so fast, even 60 or 90 minutes. And we have teams, right? My nurse coordinators, my fellows, my IT teams. I mean, we have teams of people trying to help you every day. Our social workers are incredibly important to this role. And every opportunity, it's like giving birth, right? Nobody really told you how to do this. You learn every time you advance to that next step. So every interaction with your nurse and your doctor is another opportunity to learn.
Thank you so much, Dr. Miklos. I know it's tough because it's really a balance. I think on the patient side, we hear a lot about, the phrase self-advocacy, which means just it's your body, it's your life, ask those questions. At the same time, we have these medical experts we go to, and with the endless amount of information that's out there, it's really that point. It's curating what kind of information you're really seeking. And so I think this is a great segue too into, Karen, I know that the LLS provides these printable guides, right? Questions that you can ask your healthcare team. So I'll pull those up, but if you could highlight some of that, I think that'd be very helpful for our people today.
Yes, definitely. I mean, first echo everything that both Mags and Dr. Miklos said. I mean, totally agree with all of that. And then also, looking at something like these printable guides, I mean, think of questions even before you go into the doctor's office. There's no reason not to come in with a list of things that you want to ask. Think about things when you have time to, write them out and stuff when you don't feel like you're pressured. I think that, as Dr. Miklos said, they appreciate patients that come in with questions, with someone else, and when they write things down, because it only makes you a better patient, all right? It's very easy to go to the website and to find some of these questions and to kind of pick and choose what works best for you. I think the other thing is that to be upfront if you want your caregiver involved with all of these conversations, and if you want your healthcare team to let your caregiver know about what's going on. There's all of these HIPAA regulations and stuff, but if you make it known that they should be part, and I mean really part of your care, then the care team will make sure that that is the case. But definitely, you both, Mags, you and Stephanie both said that, you learned, right? Well, what we would like today is for new patients not to have to go through that learning curve, or to make it very easy and not as steep maybe as you did, because we're now providing them with the tools that they need to make that a little bit easier.
Yeah, absolutely. Thank you for sharing that. And, I think the key is understanding, maybe what other people have learned from their time before you. And so whether it's these printable guides from the LLS or Mag's story on the patient's story, right? You read what she went through and what you learned, Mags, through the process. I think these are very valuable. I want to just segue now into the topic of second opinions. I actually do, I'm going to put a couple polls up. I kind of skipped one or two, but one I think is just about whether someone did seek a second opinion. And so Karen, first, do you have any sort of, guidance to people? I think there was a guide, a printable guide from the LLS, but just anything you'd like to add about whether someone should seek second opinions or what questions they should ask in that process.
So yes, we do have a guide with some questions that a patient can use in terms of thinking about a second opinion or what they should do when they seek a second opinion. But I think one of the things that people need to think about is everyone deserves a second opinion, right? We're talking about cancer. This is not a common cold or a virus. So you want to make sure you're getting the best care that's available. Now, also think about, is the physician that you're with, is it the right fit, right? When you talk about treatment, are they listening to your concerns? Okay. What about, the office staff? How important is how the office staff treats you, right? Is insurance a problem? Which could very well come into play. And thinking about those things, and then, there's no reason you can't tell the physician, I'd like to seek a second opinion, right? Sometimes it's just verifying what they told you and you come back to that physician. But I think that this is an important enough situation that you should make sure that you're getting the best treatment possible, not only with the disease itself, but for you as a person and what works best for you. And to think about those things. And I mean, you call your insurance companies, see where there's coverage, reach out to either us or another one of the lymphoma groups to find out where the lymphoma experts are in your area and things like that. But I think that everyone is entitled to a second opinion and should clearly think about it.
Great. Thank you so much, Karen. I want to now go to you, Mags, and I'm going to pull up something, again, you quoted in the, or you said in the story that you shared on the patient story about, look, I didn't really know. So you just went with the first opinion. Can you talk a little bit more about how you went about that decision?
Yeah, absolutely. For me, in my case, it was more of like just scared, was told it was stage 4, was told we needed to hop on it right away, was told I couldn't really wait. And I think just being, again, so young, and I didn't really know. And this was something that was super duper serious, and the first really serious thing that I had ever experienced. I trusted the doctor. I trusted the oncologist that I was assigned. Do I wish I'd gotten a second opinion? I mean, looking back now, I think it would have definitely been helpful to get a second opinion. Like I said, I think everyone should get a second opinion. But again, I think it was just at the time I was scared. I was worried that if I waited longer, it would get even worse. And I didn't really know what I was getting myself into. That being said, I do really trust the healthcare system that we have here. In my city, we have some pretty big hospitals that are doing lots of research for cancer. And so I just trusted that I was being put in good hands. I had been told by other people that I had seen prior that this oncologist was good. So I just trusted it. I'm happy that I did. But at the end of the day, I think if you think you should get a second opinion, you definitely should.
Perfect. Yeah, it's a lot of it is, there's so many different factors, right? It's the rapport that you have with your doctor and the medical team, maybe your situation. Is it a very special, is it a more rare diagnosis? Do you need to seek out a specialist? I mean, there are a lot of things to consider here. Dr. Miklos, I'm curious to hear your opinion on the physician side, right? How you approach the conversation of second opinions and any suggestions you have for patients and caregivers on that.
Well, that's a tough question, because essentially, if everybody got a second opinion, we'd be doubling the effort for what would be, you would think, something that we should have gotten right the first time. So in the perfect world, that would be ridiculous to think that everybody, I mean, not ridiculous, but it would be counterproductive. Now, I think what you might be, Mags, maybe another way of putting it would be, everybody deserves an opportunity to go to a center of excellence where they can go through that process of pathology review, multimodality review, having a tumor board where multiple experts are tuning in and giving their opinions together, so that we really can leave the room and the experience with the confidence that this is the correct therapy going forward. And sometimes that might be the first place that you were fortunate enough to be sent to by your primary care doctor. But if it wasn't the first place that you were sent to, then yeah, you should go to that second excellence. So I'm going to come back to my original statement, not so much emphasizing the need for a second opinion, but that patients with lymphoma need to have their pathology reviewed and have their case discussed in a tumor board environment with multiple experts at a tertiary cancer center. That's why these comprehensive cancer center programs are funded by the federal government and the NCI in particular, to make sure the outreach to the community, serving the patients and the oncologists in the community, who can then do a lot of the heavy lifting and build that relationship with the patient that's come to them and trusting them. So I think that second opinions just need a third name. They need that name of centralized review, the tumor board, the cancer excellence, the comprehensive review.
Right. And so it may not be at another place, but that you're getting the right process just from where you go initially. So getting multiple voices on that, I think, is sort of the key here. Actually, Dr. Miklos, I'd like to transition now into talking about treatments, period. I know, again, that we're covering a broad topic, but how would you describe for first-line primary treatment what the landscape is for non-Hodgkin's in terms of
That's a terrific question, Stephanie. And this maybe gets back to the question about, does everybody need to go to the second opinion? The upfront therapy for all of the B-cell malignancies that are called non-Hodgkin's lymphoma is almost always going to be a combination chemotherapy that we now have a name for CHOP. And this is a combination of cyclophosphamide, adriamycin, oncovin, and prednisone with rituximab added in, so CHOP-R. There have been many studies over the last 40 years comparing CHOP to other combinations, and CHOP just keeps winning. So the upfront therapy for non-Hodgkin's lymphoma has remained solidly focused on CHOP rituximab. And fortunately, 60% of the patients achieve a durable long-term remission with this type of therapy. So I hope that I'm talking to two people who were able to benefit from that straightforward therapy. These do cause hair loss. They are an every 21-day treatment. It does happen 6 cycles usually, and with staging studies using PET scans for diffuse large cell lymphoma. Those are critical elements. So CHOP chemotherapy, 2 to 3 rounds. Is it working? A PET scan, which is a therapy that uses radioactive glucose to monitor the metabolic uptake of cancer in combination with CT imaging, 3-dimensional structures that allow us to measure the cancer. And then at the end of the therapy, it should be all gone, that you're in remission and that we do not have any indication of persistent metabolically active disease. If there is, then another biopsy is necessary. That is by far the most straightforward therapy that, again, about 150,000 patients a year should be getting.
Great, thank you so much. Actually, we did have an audience question before from Matthew B., who was diagnosed with PMBCL, so same as MAGS. And his question was, what should I expect going into radiation for my PMBCL in the upper right chest? Now, I know this is a case that's not your patient, but in general,
of course. And again, now I'm wrong already. So case number 1, and I'm already wrong because we know from large phase 2 studies done at Stanford and the National Cancer Institute that a more intensified chemotherapy for primary metastatic B-cell lymphoma, or PMBCL, is necessary. And this is a drug combination that we call R-EPOCH. And it's same drugs, but more intensified, higher doses, continuous pumps are involved. And then if the patient had bulky disease with lymph nodes greater than 10 centimeters before the beginning of therapy, it would be standard of care to have a consolidative radiation at the end of the R-EPOCH. Now, this is also becoming a challenging space. And again, one of the reasons why you'd want to be seen at a center for excellence, because there is a upcoming role for CAR T cells in this disease when patients have refractory to initial chemotherapy. And I don't know when you want to talk about this, Stephanie, but the original indications for a personalized therapy that attacks the cancer using your own immune system by genetically changing your lymphocytes and supercharging those cells to fight the cancer has many advantages that we've discussed on Patient Story previously. And so these CAR T cells, I think we should at some point point out the challenge as we move something from investigational to standard of care, but in third line after you've had 2 other types of treatment, to what is soon going to become second line therapy. And you always want to have this kind of, every patient has the fear of missing out, FOMO, because it's changing so fast. And yeah, so look, I just already kind of restated what I told you, that everyone should start with R-CHOP, and I just pointed out that no, you should get R-EPOCH. And then should you get radiation? Well, certainly in the past, yes, but should you be considering in the future potentially going with a CAR T cell? And the answer is not today, because we don't have that indication, but probably that will be the therapy in December. And today your question is very appropriate. You should probably be getting radiation therapy. And if that is it's really a judgment call with your oncologist, radiation oncologist, and that tumor board review as to whether you should be receiving chemotherapy, another type of chemotherapy in addition to the radiation therapy, or did you have a very good response, potentially a complete response with the upfront REPOC and the radiation as a consolidation. And again, I don't have all your details, but you're getting a sense of how complicated this can be. And imagine if you get into, second, third, or fourth rounds of therapies where other things have already not gotten you a lifelong cure.
Yeah, and I appreciate you even tackling that question, Dr. Miklos, because again, these are not your patients, and I know there's a lot of different considerations. You have to know the patient history, but I'm glad you also brought up the CAR T, and that, there's a lot of new research and clinical trials and things happening, and already approved different lines of treatment in this space, which, as someone who was diagnosed with non-Hodgkin's, makes me feel a little bit better, just the in case. And for people who want to dive into more of Dr. Miklos's research and what he has to say about this, please go to the patient story. We'll drop that link also later. I do want to ask Mags now. You went through RCHOP, as Dr. Miklos said, that's the standard. Can you just describe what that was like for you? And then we're going to, segue into side effects as well. You could talk about the hair loss and stuff like that.
Yeah, absolutely. It was exactly as he said. I chose to do it through an IV. I didn't want to pick or port. However, I know that's not an option for everybody, but I chose to get IV. It was 6 cycles. It was like a full day of injection. So I would go in at about 9 a.m. and then I would stay there until about 4 p.m. And then I was done for the next 3 weeks. I would say that the side effects probably lasted a week for me. The biggest one was obviously the hair loss. I lost my hair 2 weeks after my first treatment. Second would definitely be the nausea. The nausea was probably, I think, the hardest one to manage for me, just because you just constantly felt sick. Otherwise, it was headaches and just really like loss of energy. Minor things such as mouth sores I'd get from time to time, constipation from time to time. But I think the major ones for me were definitely the nausea and the headaches. I tried my best to not have to take medications for it. That was just a really personal choice. I tried to do, just like ginger, or just really finding what kinds of foods worked for me. I knew that for me personally, smell was a huge trigger for my nausea. So I would just try to eat bland foods, not have things with smells. When it came to headaches, I would just try to rest as much as I could, drink water, cold or hot, whatever felt better at the time. And just find my own little ways to manage my side effects. And then I think the first 2 rounds were definitely the hardest because I didn't really know what to expect. But I think as the treatments progressed, around 3, 4, 5, 6, I was able to manage them a little bit better, although my body was getting weaker. So but I do think they vary from person to person. However, I've been told that the side effects that I had are pretty common for the regimen that I did.
Yeah, thank you for sharing that. And of course, for these are the pictures that Mags had sent in to show what what you were going through treatment. And it's of course depends on the person, right? Everyone sort of has different side effects and it impacts them differently. I know for some people, in the beginning it's easier and then it gets harder because it's cumulative. For other people, they say, like you did, you kind of know what to expect and then you can handle it better, so it gets better in that way. So one thing I would like to offer is just getting out ahead. So especially with nausea, for me, it was, if I felt it, it was too late. Like as soon as I was chasing, it just was way too overwhelming. And so I took the nausea medication beforehand, for instance. Great. And I want to talk about the hair loss too, Mags, because that's such a big topic for people. And you had also mentioned about wigs and how you bought it, but you didn't really use it. Just if you could give us a summary of what that was like for you and how you made those decisions.
Yeah, so like I said, I lost my hair probably, I think it was 2 weeks to the day that I started my first treatment. I remember my friend was like, "Oh, your hair's still here." And I was like, "Yeah, I haven't felt any hair loss." And then later that day, it was just like I had clumps coming out and I was like, "Great, here we go." It was probably about 4 to 5 days until it was just so bad that I decided to completely just take all the hair off because it was harder to watch it fall rather than to just shave it all off. I did choose to get a wig. I think for me, especially at first, when I was told that I was going to lose my long blonde hair that was super heartbreaking for me. Obviously, I asked if there's anything that I could do to stop it. The oncologist said, you can try this and this, but your hair is probably going to fall out regardless. So you might as well just, kind of accept that now. So I did go and buy a wig. My wig experience buying it was not the greatest, but I think with the information and the resources that I had at the time, it was just the best decision that I could have made for myself. I did wear my wigs whenever I left the house. I wore them until about, I think, 6 months post chemo. That's when I stopped wearing the wigs. But when I was at home, I definitely felt more comfortable with nothing on my head. If anyone's worn wigs, it's not the most comfortable thing in the world. And so wearing it all day, it's not fun. But yeah, I found different ways to use headscarves. Baseball caps were wonderful, even just toques. So really it was just kind of dependent on where I was going, what I was doing, what I was in the mood for.
Perfect. And just to second that, wigs are really uncomfortable. I spent a lot on a natural, human hair wig and used it maybe like 3 times. And the third time was for my wedding because I was like, I don't want to walk down the aisle bald. So thanks for sharing your experience, Mags. By the way, for some people, if you wear the baseball cap, they have hair like that's attached to it. And that was more comfortable for me because it wasn't itchy. It was a, cap material as opposed to the wig material. So some, tips from former patient. And Mags, we have a question I'd love to answer live from Belinda Santos. She asks, my husband will begin chemo soon. Should I plan to be there with him at the infusion center all day? Or is this something I can drop him off for and return to pick up?
I think that also depends on what the situation with COVID is, because currently where I live, you can't have somebody with you at the time, but I don't know what it's like where you live. I definitely found that it was helpful to have somebody, just because I'm a very independent person and I didn't mind being on my own, but I was there all day long. And yeah, the nurses come check in on you, but you're by yourself. You're kind of just sitting there. So I would, bring books and stuff, but it was definitely nice just to have my boyfriend there, just to talk or just to watch a movie together. Even it's just that comfort of some sort of comfort or something that close to you. And I could get him to get me snacks. So, that was also a bonus.
Right. Yeah. And so as you pointed out, it's a good point. COVID, maybe there are different sort of guidelines and depends on which hospital or healthcare provider you're at. So definitely if you can, and if you're allowed, then it's nice, I guess, to have the company. And for R-CHOP, I actually underwent R-EPOCH because I had a slightly different sort of diagnosis. But for R-CHOP, it's the one infusion usually, right? Once, and then so maybe for that situation, if you have the time, hanging out in the infusion center gives the patient something to do to, pass the time and feel less lonely. So that's ideal. And I'm so glad that COVID is sort of, hopefully with the vaccinations happening, will allow for more of that to happen. I would like to address another attendee question. Let's see here. Yeah, so I'm going to share it up here. It's live, and I also got one submitted. So Dr. Miklos, this is to you. It says, I am on the R-CHOP chemotherapy. How long after that last cycle does it take to recover, build white blood cells, and start to feel normal again? So to the best of your ability, if you could answer that one.
Sure. The recovery from R-CHOP, R-EPOCH, combination chemotherapy is both been relatively effective within 3 to 4 months. Okay, so I'd say 3 months would be my quick answer to after the conclusion of the final cycle of CHOP. But with the following caveat, that is, unless a pandemic comes along. For example, this year, we all have faced the issue of how do we get vaccinated against an entirely new antigen, the COVID vaccine. And you all must be aware by now that rituximab has been identified as one of the risk factors for having a poor antibody immune response to the treatment with the vaccine. And so while your immune response that you've developed over a lifetime, which is maintained in mature cells, mature T cells, mature plasma cells, is intact, and it's really relatively resistant to the chemo that we're giving, the ability to make a new antibody T cell response to a vaccine or to an infection you get during the actual treatment is greatly limited. I think a longer discussion would take a lot more time than that. But just to say, in general, you're good to go in 3 months, okay? And then I think, Stephanie, you and Mags could probably give a better answer. Were you good to go in 3 months? Did you feel good to go in 3 months?
Yeah, that's a great question. I'll do a quick answer and then Mags to you. I actually ended up dealing with neutropenia for like a couple months after. And so yeah, it took some time. Like I think you said 3 months or so. I think that was about right for me. Mags, I don't know if that's what the case was for you. And maybe if you could address, I mean, I don't know, normal means something different to everyone, but just maybe being able to like have the normal energy levels again. How long did it take you to get there?
Yeah, definitely. Not that I can remember the exact amount of time, but I definitely remember feeling really weak after my last round because I think, the body's been through so much that it was definitely a recovery. But I would say probably about 3 months is like a pretty good, pretty good. I think I really tried to like kind of start putting myself back into like normal life by like going for longer walks and like trying to do things that I was able to do more so towards my normal routine. And I think that definitely helped me. But I'd say, yeah, 3 months is probably like a good timeline to guesstimate.
Yeah.
And Karen and I are probably going to have to remind you young kids that not everybody is as young as you, and that the average age for non-Hodgkin lymphoma is probably 65. And so we have a lot of patients who are elderly, and going through even dose-reduced mini-CHOP chemotherapy can leave them weakened for a much longer period than 3 months. So obviously we need to take into consideration where you started coming into the treatment and what your expectations will be afterwards. Thanks.
Absolutely. No, that's a great point. There's so many factors to consider. And actually, Mags and I were diagnosed with the same. That tends to trend more young and female, which is the primary mediastinal, and less so the DLBCL. And on that note, Dr. Miklos, we did get Laura B is a DLBCL caregiver, and she just was wondering, is there anything someone can do to prevent or slow the blood counts from dropping? And I guess she might have heard about vitamin C infusions. And so I'll leave that to you.
Thanks. So I always remind people I went to a medical school and not to a nutritional school, so I have to limit my comments here. The chemotherapy that you're receiving is designed in order to interfere with cell replication and with the growth of cancer cells. And that's going to have an effect on the normal cells that are reproducing all the time. Blood, which has to replicate, your platelets last 5 days. So you're making platelets all the time. And red cells may last 100 days, but you're still having to refill your entire body with blood. Think of mucositis. Think of the mucosa from your lips to your anus as being a very sensitive site for the chemotherapy effects as well. So it's very difficult without this targeted therapy to get the benefit of chemotoxic medicines that doesn't impact the normal cells. And if you were to find a shortcut through reducing the dose or adding an antidote that prevented that kind of killing, you would probably be decreasing the benefit to the tumor as well. So when your doctor says, unfortunately, this is probably going to require 20 days to recover between cycles, that is probably going to take 20 days to recover between cycles. Stephanie, you brought an interesting point up. It sounds like you had recurrent intermittent neutropenia, which is a side effect that can follow rituximab B-cell aplasia. And it's unpredictable, and it's hard to know who's going to have that problem. And you probably got a lot of shots of GCSF along the way, the growth factor that we all make in our bodies all the time, and it has names like Zarzio or Neupogen. So there's an example where you can overcome a deficiency that was due to the therapy, and that lab testing was helpful to you to stay safe and know that you're not going to have infectious risks. So there are solutions, but vitamin C is, I like a well-balanced diet. I encourage my patients to take a multivitamin, but I don't encourage supplements or large things that require spoons to add extracts into your diet. No, that's not good. Healthy diet, and focus on protein when you're recovering from chemotherapy. Avoid the carbohydrates. Focus on the rebuilding of the body. Protein.
Perfect. Thank you for that. And I actually do want to, we have Ed F, who's a DLBCL patient. I'm going to just share his question on the screen. He also asked it live, but we have it here, which is, just completed 6 R-CHOP cycles for ABC type DLBCL, was vaccinated prior to diagnosis. When should I get revaccinated for COVID-19?
That is an excellent question. Thank you, Ed. We're all studying our patients at this point, trying to understand Will we expect the cancer patients who, like you, fortunately got vaccinated beforehand? I actually think you'll have a very durable vaccine response. Again, the mature plasma cells and T cells are going to be relatively resistant to the therapies you just got. So I think you are relatively protected. The patients who didn't get vaccinated before they were able to start the therapies because maybe the cancer came, during the pandemic itself, those people are going to probably need to be revaccinated. We don't know how to advise them yet. There is some literature even today that says that some of our patients should be getting 3 shots, not 2. And so we're struggling with limited data as we measure the immune responses to the therapies right now. I'm sure some of you at large cancer centers have been asked to participate in research studies where we're collecting extra tubes of blood 3, 6, 12 months after the vaccines in order to see how durable your responses are. So thank you if you are participating in those.
Perfect. Thank you so much. And I do want to, we have so many questions going on, but I do want to shift it before we move too far down to Karen about, I know there are suggested questions by the LLS in terms of side effects and treatment. So we'll pull up some slides, but yeah, Karen, if you could talk about that.
Sure. So I think that what patients should do is, think about some of the things that are important to them, right? I mean, you both talked about hair before. There are patients that losing their hair is more of a crisis, say, than constant nausea or something like that. But have the conversation with your provider about what are the expected side effects, right? I mean, there are going to be a lot of general ones, and there are going to be side effects that you just don't encounter, or that you will, right? Everybody's different, as to Mag's point before, but being able to have that conversation with the healthcare team and to be prepared for what may happen is always good, right? And then, again, to some of the things that Max talked about is like, what can you do maybe to minimize them? You may not be able to always minimize the side effect, but at least to take care of it. Stephanie, you talked about taking the antiemetics in advance, right? Because who wants to be nauseous? You didn't even want to get to that point. So if that's the case, then yes, talk to your doctor about what are the medications that you can take to avoid the nauseousness to begin with. Or if it doesn't matter, can you take something afterwards? Also, when they were talking before about the vitamin C, most of the bigger institutions, if not all, you can have access to a dietitian, to a nutritionist. I would say that you should take advantage of that, but then always go back to your doctor with whatever is being suggested, because you want to make sure that whatever supplement or vitamin or other type of, complementary medicine, as we call it, does not interfere with your treatment, right? Never just take something because it sounds good or that it was suggested as a possible thing to take. Always go back to the doctor. And I think that the other thing is, which is always very helpful, is to talk to other patients. How did they deal with a particular side effect just on a practical level, right? And then you'll find what works for you, what doesn't work. Again, Max talked about, things like smells and going with more bland foods and stuff. I had a patient that told me one time that the only thing that she could eat was hot, spicy foods. And I kind of it did exactly what you both did, right? I'm on the phone with her and had that look on my face. It worked for her, right? Wouldn't work for somebody else, but it worked for her. But again, getting suggestions, see what works, and then always the bottom line is making sure with your physician, with the healthcare team, that what you're doing does not interfere with your treatment.
Absolutely. So that's like the most important sort of conversation. But I know Kieran talked about it and Dr. Miklos too. There are teams right? So, you've got your, your oncologist, and or hematologist, and you've got maybe you have a radiation specialist, you have social workers at the hospital, you have nutritionists. So, and nurse practitioners and nurses who know a lot about side effects and management as well. So, don't be afraid to seek out those resources. Hopefully you have them. I do want to lob another question here from our live Q&A. Grace Ing says, I'm a young patient getting my last chemo treatment this week. I don't know what near or long-term damage the chemo has done in my body. Do you have suggestions for recovery and restoring the body after chemo? Some external things I notice is I get tired from walking and my skin is dry and damaged. So anyone who wants to take that, feel free.
Emphasize that there's a role for, it's a terrible name. I'm going to use it just to distinguish. It's a good name. It's a good goal. Survivorship programs. I hope that we'll come up with a better name than that, because I hate to think of the non-survivorship programs. And so what I like to think about is the care continuum. That what you're going through frequently in the beginning is overwhelming lack of knowledge, needing a lot of support, needing good care, immediate expert attention. And then as you go through this process, you're going to come up with a lot of those questions that, what should I be doing about mammograms? What should I be doing about health maintenance? What should I be thinking about in regards to whether the radiation therapy has changed my lifelong risk for coronary artery disease? And so, again, comprehensive cancer programs really have a requirement that they have these survivorship programs in place for patients who've completed their therapy, to provide them a summary of what the therapy was, to provide them a plan for what type of body surveying, follow up with your local docs, primary care docs, and am I at increased risk? Should I be going through more skin dermatology reviews? What else should I be thinking about going forward now that I've gotten past the first year or more of my cancer therapy? Guys, we need a better name than survivorship programs.
I do like Thrivers, just because I know survivor has this weird connotation. I consider a survivor anyone who just starts treatment. You just, as soon as you get there, that's what it is. But I know we're coming up on time. We have so many questions I'd like to get in. I do have two I'd like to spotlight for you, Dr. Miklos. We could quickly cover so we can just spend a few minutes on the last section here. But here are the audience questions. Is it necessary to get scans regularly post-chemo after getting a clear scan mid-treatment? That's from Cher, a PMBCL patient. And an anonymous caregiver asked, is a PET scan the only way to, quote, tell that it's really gone?
Okay, timely question. So it is necessary to have scans. First of all, it's very necessary to have your therapy full dose on schedule. Okay, I want to just say this again. Everybody, of course, would like to have it more convenient and to have it change in a way that they can handle their trip and all this. But these therapies are designed with kind of a tempo of the cancer cell recovery, and we don't want to let that cell get to get an advantage. So full therapy on schedule is really an important theme you and your doctor should try to maintain. So then the question becomes, so getting these scans in a timely manner, so that it doesn't slow down your therapy is really important as well. Knowing that a PET scan should be obtained around 16 to 18 days after the therapy that you're trying to assess, knowing that then you have 3 or 4 days to look at that PET scan and still stay on schedule for that retreatment at day 21. That's a really important concept. And PET scanning is doing two things. It's measuring the size of the tumor, and it's looking at the metabolic activity of the tumor. Is the tumor dead, or is it still dividing and taking up that radioactive sugar? So that metabolic remission is the only way we can measure it by a PET scan. Just to jump ahead, there might be new things in the offing. We just published this week a study looking at a blood test that measures the rearrangement of a DNA marker that's unique to your patient's cancer that can be obtained commercially going forward. It's a shameless plug, but this is next generation sequencing of the B cell immune receptor and then measuring the tumor at a distance by sampling that DNA floating in the liquid component of your blood. And this is how research develops. And I'll just say Dr. Matt Frank and I published that in JCO last week. So, but today, the real time today, PET scans and CT scans and a normal CBC with your doctor is the way that you manage your patient's disease response and knowing what's next.
Oh, perfect. Thank you so much, Dr. Miklos. I do want to go into this section now, and for anyone who has an open question, we'll dedicate a couple minutes in just a second. But first, the support mentally and emotionally after getting diagnosed and through treatment, and then even after, is a huge topic. So Mags, I'm going to throw this one to you. If you could just sort of talk about how you tended to your mental and emotional health. And then there's a question here about how you were able to handle the diagnosis socially and to what extent you shared it publicly.
Yeah, so I actually shared my story really publicly. I kind of went on YouTube, on Instagram about it. That wasn't the plan from the beginning. I really wanted to just kind of fly under the radar, get this over with, and then come back up after I was done treatment. But then I just kind of thought about it, and I realized for many different reasons that I actually wanted to share my story. That is how I ended up finding my community. I think for me, managing my emotions was really through my community. I was able to find not only people that were similar age as me that were going through cancer at the same time as me, but people who had the same diagnosis as me. And I think there's just like a certain level of comfort when you can talk to somebody who gets exactly what you're going through. Yes, you can talk to your family. Yes, you can talk to your doctors, but nobody really knows what it's like to go through cancer better than someone who has gone through cancer or is going through it at the same time. That is how I found out how to manage certain things, how to find out kind of like which questions to ask, what I could potentially look like. It was also very helpful for me in my recovery, you know, following a girl that was months ahead of me in her hair growth process. And that gave me motivation, and that really helped me emotionally feel better that in 6 months, this is what my hair might look like. And, you know, things like that, or, oh, they're able to go back to work. They're able to go back to their life. And that gave me the motivation that, you know, it's coming for me too. And that eventually that will be me as well. I did actually begin therapy after completing treatment to deal with some things, but looking back at it now, I really do wish that I had done it through treatment because I think it would have been very beneficial for me. And so for people who ask me how to do it, I say give it a try. I know that therapy is not for everybody, but I think giving it the try and seeing, I was recommended to a therapist that worked with the cancer center that I go to. So he kind of already knew what he was getting himself into, what he was dealing with when it came to cancer patients, and how to manage what I was going through and my types of questions. So if that's something that you're open to, I think it's definitely worth looking into. Such also support groups. There are so many on Facebook, on Instagram, through the hospitals themselves, maybe not in person at the moment, but through Zoom. So I definitely think that there is lots of support out there, and that people should reach out and find what kind of works for them. As we mentioned earlier, not everything works for everybody. And so you can kind of see what's out there for you and just pick and choose what would be best for you.
Oh, awesome. Thank you, Mags. And I want to ask Karen about a different kind of support too now, which is the financial aid support. You know, for many people, maybe insurance will cover a lot, but for others, it might not be the case. We have so many different situations, and financial toxicity is the term that we use. What would you like to let people know on how they can better understand their options?
Well, I think that one, they should talk to, if there's someone available, a financial aid counselor at the institution or the group practice, if there's someone, because they'll know exactly what they're dealing with in terms of costs at the time. But then also to reach out. You know, our information specialist can give information on all of the different programs that LLS has. But then also there's other groups such as Triage Cancer. You know, they have a wealth of information and can help patients find the right type of assistance that they need. Patient Advocate Foundation. There are so many groups out there that have various different types of funds. It's really just a matter of making that phone call, and do not feel embarrassed. I think that's one of the biggest things. You know, this is a very expensive proposition, and I think that I can't say that there's anyone that goes through it without not needing some kind of help, right? So you should definitely reach out, let them know, you know, what you're going through. And then, you know, most times, whoever you're talking to on the other end of the phone, regardless of which organization it is, they can kind of walk you through as to what's out there and what might be appropriate for you. And then know the questions to ask to kind of make to trigger what it is that you should be looking for.
Appreciate that, Karen. Thank you. I know we're over time and I want to respect. Oh, Dr. Miklos, yes.
I want to make sure that everybody knows that you have the right to participate in clinical trials, that Medicare patients, that's supported by law. And so, all of you above 65, you want to participate in a clinical trial and somebody says that you're not covered by insurance, you just need to go to a different doctor. That is not the situation that you should be hearing. It does vary from state to state when you're under 65, and so I won't get into that debate, but clinical trials can be a way to avoid the financial toxicity and at the same time receive the cutting edge therapies. We are, as physicians and researchers, trying to advance the field, and frequently we're looking at what is the standard versus what we think is really much better based on a lot of data. And you can again avoid high risk trials by looking and educating yourselves on how advanced the research in that field is, phase 2, phase 3. And again, LOS is a good place to reach out to try to litmus test whether or not that would be a good study for me to participate in. Karen, I think that's one of the things LOS does the best.
Actually, I was just going to bring that up. If anybody is interested in finding out more about a clinical trial, needs a search done, we have our clinical trial support system with our nurse navigators who specifically walk the patients through from beginning to getting on a trial, if that's the case. It doesn't always mean that that's where they end up, but they will at least take them through the whole process. They will look at any of the barriers that may exist. They'll talk to the physician, they'll talk to the investigators, the primary investigators, and help them through the entire process. And if for some reason one trial doesn't work out, they will help them, look further. But definitely, if a clinical trial is even, anywhere in your mind, I would suggest reaching out to us and we can help you.
Perfect. Yeah, there's so many resources. I'm so glad we're able to spotlight, the ones that are at the LLS. And we have a section on thepatientstory.com where we, say if you're looking for a particular kind of help, whether it's financial or lodging or transportation, we'll have our suggestions there as well. I want to be respectful to all of your time. And so I want to just, there is one question here I wanted to throw out there, and then we can end with your final sort of thoughts or last message to the people who are here today. It's just about scans. I think this is one that's really popular, so I just wanted to throw this to you, Dr. Miklos. People ask about regular scans. Can they lead to increased exposure to radiation and hence increased risk of cancer? I mean, this is something that we hear a lot. And then the second part of that is it necessary to get the regular scans even after getting a clear one without experiencing symptoms?
Well, sometimes your insurance company helps you avoid this conundrum anyways. And Medicare's policy would be 3 scans following a therapy. So that is often going to be limited. Another reason to develop blood tests that are going to avoid this problem. Regular scans are disease specific and they never extend beyond 2 years following the diagnosis of the cancer. We've learned through many prospective studies that the patients are the ones who are at that point telling us about new symptoms and concerns that their cancer may be back. It's very unlikely. In fact, many studies have shown regular scans do not pick up the cancer in the period of time beyond the bulk of patients' recurrences. It won't surprise you that we ask for, with diffuse large cell lymphoma or primary immune stem, these aggressive lymphomas, that we ask for scans at 3 months, 6 months, and 12 months after therapy, because those are the time periods when recurrences are going to occur, and capturing the cancer early before you're symptomatic on a scan like that can really improve your ability to move to another therapy seamlessly and without some of the toxicities that come from the overwhelming growth of a cancer.
Thank you so much. And Dr. Miklos, what is your last sort of message? We're going to go into the round of last messages for people as we wrap this.
Information is power. These webinars and patient-focused information sites that are well curated, like Patient Story and Leukemia Lymphoma Society, are absolutely essential, doing a service to both the patients and to the doctors. Thank you for doing this, Stephanie. Thank you for being here today, Karen. And Mags, thank you for sharing your story.
Thank you so much, Dr. Miklos. I'm going to spotlight, Karen, what's your last sort of message to people here today?
I think echoing what Dr. Miklos said, and just understand, don't do this alone, right? We're all here to help, as little or as much as you need, but don't do it alone.
Perfect. Thank you so much, Karen, for your work at the LLS. And Mags, if you could wrap with your final thoughts.
Absolutely. I say ditto to Dr. Miklos and Karen, whether that be from information from something like the patient story from the LLS, and just adding to that community, having a community of people who understand you, who are in the same situation as you, helps you so much. And it helped me tremendously. So I'd highly recommend whatever form works best for you to reach out and find a community.
Perfect. Thank you to Karen, to Max, to Dr. Miklos for joining us today. And for those of you who were able to join today as well, if you have a question that wasn't answered, we'll try to get to that. So just sign up for our community and we'll send you an email. But everyone have a great day. And again, thank you so much to our awesome panelists for sharing their thoughts today. Thank you so much.
Thank you, guys.
All right. Take care, everyone.